What did you say? Who is waiting to get in? No, everybody. I think everybody.
All right, it's Catalina Ortega.
I think she's gonna have to go out and come back in like everybody else got in. There's not an option for me to do that.
Okay, I'll let her know right now.
All right, thank you. All right, anyway, back to this. April 9th, you guys will be turning in your paper. You upload it, and don't forget to cite your references, because that's a good, easy bunch of points. The renal patients that you guys take care of in the hospital, I'm pretty sure everybody's had a patient that's been on dialysis at least once. And if you haven't, it's really a good idea to assess that those shunts and the grafts, because those are super important to this section. Kidney anatomy and function is just, these are just basic review, but what's generally causes the kidney dysfunction and the renal failure are non-compliant hypertensive patients or non-compliant diabetics. Now, every one of you's had a diabetic or a hypertensive patient, because that's what we get in report every week. I have a 58-year-old diabetic with hypertension, GERD, hyperlipidemia. Well, the kidneys suffer from those diseases, and it's so prevalent in our society, in our hospital. I mean, I don't think there's one single one of you that hasn't had a kidney patient, a patient that suffers from some kind of kidney injury, insult, kidney dysfunction. So taking care of your kidneys are super important. And I worked for a while at the dialysis center, and I saw just the struggle that those patients go through. And I mean, they're struggling to, live everyday life, and they have to go 3 times a week. Some of them go 4 times a week. And I don't know if any of you have family members or friends that have been on dialysis. It's a hard life. It really is a struggle. And taking care of these patients, I feel like almost when they're in the hospital, they almost get like a little break, meaning that they still have to go to dialysis while they're there. Sometimes the dialysis machine comes to them at their bedside, but they just get wheeled over. They don't have to get in the car, get out, go in the cold or the hot, get in their chair. They just get taken right to dialysis. And if you have a patient, really important to let your clinical instructor know that you're studying it and that you'd like to go with them. And even if you have 2 patients, just ask to be excused to go watch the patient get on dialysis, so you can watch that process. And then they're going to be there 3 or 4 hours. You obviously don't get to sit down there that long. Go back and take care of your other patient. And then you will be able to go back maybe when they're coming off the machine, or you'll receive them when they're done with dialysis. Has anybody gone to dialysis this semester? Wow, nobody. That's too bad. How about last semester? Oh, come on, you guys. Oh, well. This semester, if you have a dialysis patient, go with them. How's that? So the kidneys excrete waste products, the metabolism from the body, regulates levels of electrolytes, balance of water and salts, regulates the blood pressure. And that's a big one. People with hypertension usually hurt those renal arteries and veins and end up, with a problem. Helps regulate the blood pH. It produces the erythropoietin that regulates the production of the red blood cells. So the erythropoietin is also something that Amgen has come up with several years back. And it's an epigen shot. And the patients, you get Neupogen for the white blood cells, epigen for the red blood cells. And it's an injection that is very, very expensive, but it's so important to these patients because it makes them feel better. It's like a boost. They get this subcutaneous injection, and it builds the red blood cells. Super important to remember too, when you're pulling up that subcutaneous injection, you get every drop. I really can't tell you how much they are, but several years back, they were like $3,000 for a tiny little vial. And some patients get them after each dialysis treatment. So insurance is still covering them. And I don't know why they're that expensive. Hopefully they're not anymore, but they do help build the red blood cells. And when we talk about hemodialysis, you'll see the destruction of the cells and why they need it. The kidneys convert vitamin D to calcitrol, which increases the absorption of the calcium and the phosphorus. So these patients definitely get supplements. The patients that are on dialysis, they get the supplements. And if you've had those patients in the hospital, they're huge tablets and they hate taking them. Nephrotic syndrome, damage to the kidney that leads to the loss of protein in the urine. There is no occlusion of the glomerular vessels. So if we go back and you see the glomerular vessels here, you can kind of see how the kidney runs, but there is no occlusion. Characterized by proteinuria, hypoalbuminemia, and edema. So the lower rate of albumin in the blood. Primary age affected is age 2 to 5 years for boys. It's 2 to 1. And the nephrotic syndrome is like, if you look over here and you're seeing the different symptoms, inflammation of the glomeruli, hypertension is the big one, oliguria, coke-colored urine or blood in the urine, peripheral edema, massive proteinuria, the hyperlipidemia or hypoalbuminemia. I said it right this time. So this is just for the nephrotic syndrome. And if you see a person that has this look to them, you'll see maybe they're a bit puffy in the face, a little bit jowly, and their eyes maybe a little bit swollen. You can kind of look at a person and say, oh, they look like they have some kind of kidney problem, some kind of nephrotic syndrome going on. Peripheral edema, massive proteinuria, hypertension, hyperlipidemia, hypoalbuminemia, and recent weight gain. So they get kind of puffy, kind of swollen. And if you see nephrotic, the mnemonic is sodium decrease, albumin decrease, proteinuria is greater than 3.5. The hyperlipidemia is one. And the patients with hyperlipidemia, you've taken care of many of them, I'm sure. They take the statins, but a lot of times those do interfere with your renal function. A renal vein thrombosis, orbital edema, where the eyes are super puffy, swollen, thromboembolisms, they get infection, and that's due to the loss of the immunoglobulins in the urine. And then the coagulability due to the loss of the antithrombin 3 in the urine. So nephrotic syndrome is something that you'll see in the hospital. You'll see a patient with that coming in with something different. I'm going to try to play this because this is a pretty good one and it's not long. Let's see. Can you hear it? No.
Negative.
I'm going to try something. Let's see. Nope. Where it says more, it sometimes says you can share sounds. In the first video that I started, I had the share sounds, but this one I don't. But I would like you to look at this after, because he really spells it out and he shows how the kidney functions and he shows the pathophysiology. So please watch this one. Corticosteroids and cyclophosphamide are a treatment, prednisone for 4 to 6 weeks, and then remission is obtained when the urine protein is 0 to 20 for 5 to 7 days. Now, the corticosteroids and the prednisone are something that you're not going to be taking all the time. You kind of save it up until you get an exacerbation. Albumin followed by the furosemide may be given for the edema, and albumin you can give in the hospital. It pulls the fluid into the right place, out of the vascularity and back into the circulation. Management of diabetes mellitus, of course, and then the treatment of the edema with the loop diuretics, the thiazides. Usually if it's a severe overload, the patient is going to be on telemetry because you want to watch the cardiac status. And then the lipid lowering agents or the statins is what you'll take. That's generally the treatment. assessment and interventions, we monitor the urine, we monitor for edema because they could be very edematous and at the same time be dehydrated. So usually if that is the case, albumin is given to get the fluid pulled back into the vascularity and out of, the edematous areas like their legs are edematous, their face, their arms. And it's kind of a slippery slope, I would say. Possible fluid and salt restriction and increase in protein. Monitor the eyes and nose are without, they sometimes get weighed 3 times a day. Vital signs and symptoms of any infections. That's something that we are really diligent with. Administer the medications on time. Okay, some of these patients will already be on a very strict medication regimen, but in the hospital, it's a little bit different. And primary nurse, case manager, physicians, they try to work with the patients. So whatever is best for the patient. So what works best for the patient? Promote and provide rest for the patient. We monitor their labs. Hand washing and monitoring visitors is important because hand washing, of course, for everybody, but you really have to know that the patients that have nephrotic syndrome may be so compromised, immunocompromised, and any little thing can cause an infection. So you want to make sure that you're monitoring their vital signs and symptoms of infection, but also not exposing them to anything that, like a little kid that comes in now that there's visitors again with the sniffles, or somebody, oh, it's just my allergies. You have to be really careful with them. They do get a very puffy face, kind of a large belly where the rest of their, their trunk, their extremities are thin, or there's a edema in the legs, and you can see, the lower part of the legs being very edematous. Let's see. There's an acute glomerular nephritis, meaning that it could be this inflammation of the glomeruli. It could be secondary to a past infection, like again, that strep. People don't take strep as serious as they should, but it says antibody antigen reaction secondary to the infection, like strep. Immune complexes become trapped in the glomerular and may cause occlusion of the vessels. So hypertension, red blood cells in the urine or tea-colored urine, elevated BUN, and anemia. Sometimes these patients get very drowsy, headachy, dizzy is one of them that's not mentioned, diplopia, and vomiting. Two-thirds are 4 to 7 years of age, and they're usually boys. The prognosis, 80% favorable. That's pretty good. Good reoccurrence is rare for the glomerular nephritis, 80% for the nephrotic, but for the glomerular, it's usually rare to have a reoccurrence, but so that's a good thing. It could be many different things, but primarily the glomerular nephritis is post strep infections. That's one thing, like somebody gets a sinus infection, a strep throat, and they don't complete their entire antibiotic regimen, that could be really detrimental, especially to a young kid, because you don't want it to affect the kidneys. Antibiotics, diuretics, and antihypertensives are usually the medical treatment. But again, of course, we always monitor their eyes and nose, and blood pressure is definitely a priority assessment, because if their blood pressure is extremely high, then you know that the treatment isn't working. Oliguria, you restrict protein in diet with oliguria, no P, no potassium. So fluid restrict, frequent rest periods. And in all the years on pediatrics, I've only seen maybe one kid with the glomerular nephritis. One little boy who was about 7 years old, and it's been a long time. So I'm not, really sure what the rate is of that age of kids that come in, but we've only seen one, and we really, honed in on that little guy. He was from North County, and he did fine. He got, antibiotics, diuretics, and his blood pressure was surprisingly a little bit high. I like the pictures because they kind of help me remember what I'm looking for. Nephrotic versus acute glomerular nephritis. Nephrotic syndrome causes primary glomerular disease, and then acute glomerular nephritis antigen antibody reaction to an infection. So the syndrome for the glomerular nephritis versus the nephrotic syndrome, you have a much better prognosis with the glomerular nephritis, and the treatment altered immune responses, so antibiotics, antihypertensives, steroids, and maybe blood. For the nephrotic syndrome, steroids, Lasix, and albumin. And I do know that the nephrotic syndrome takes a little longer to get regulated and to get you back to, where you can be stable and be discharged, as opposed to the glomerular nephritis is a little bit faster. Renal failure. We take care of a lot of patients in renal failure, and renal failure results in fluid volume excess, so the patients can't get rid of the fluid out of their vascularities, electrolyte imbalance, impaired red blood cell production. So the production is decreased, and in renal failure, I told you the erythropoietin is not being made. You have to get it supplemented, and the accumulation of the waste products in the blood makes the patients, not only do they feel bad, they smell bad, but they get almost poisoned in their brain to where they can't think straight, they can't see straight, and then blood pressures that are all over the chart. Now, if you've had a patient in the hospital and first thing you do is you go in, you get your assignment, and they're a renal failure patient, chronic, acute, you open up their labs and you're like, what it's all different colors. Every lab value is off. That is a definite for dialysis patients or acute renal failure patients. Their labs are always off. They go to dialysis, they get post dialysis lab draws, and they're a little bit better, but not that much. Definitely not that much. So you will see that, like, when you go to give report and you say, well, their labs were, and you can explain, my patient is in renal failure, their labs are all over the place, get them point, the hemoglobin and hematocrit and the electrolytes, and just say all are off balance. Going to dialysis at 9:00 this morning, and they will do a post draw. After dialysis, they'll do another one. So a pre-renal acute failure, sudden or severe drop in blood pressure, shock, an interruption of the blood flow to the kidneys from a severe injury or illness. Intrarenal is a direct damage to the kidneys by an inflammation, a toxin, could be drugs, an infection, or a reduced blood supply. We'll come back to that second one. And then post, sudden obstruction of urine flow due to an enlarged prostate, kidney stones, a bladder tumor, or an injury. When you see the intra, it says direct damage to the kidneys, and it says reduced blood supply. This can happen, let's say a patient is in the OR having a CABG, coronary artery bypass graft, and there's some slight complication and not enough blood is circulating, and there's a reduced blood flow to that kidney. There can be a kidney injury and cause an acute renal failure, meaning that this patient may need a transient dialysis session while they're in the hospital until their kidneys regain their function again. It could just be an acute transient attack on the patient's kidneys or like a severe trauma, like a horrible car accident, boat accident, plane accident, motorcycle accident, where they were not getting the blood supply to the kidney, and they may need to have, dialysis, a port put in, a line put in, and while their kidney is getting back to normal, they will be dialyzed while they're in the hospital, while the injury heals itself, so to speak. A post-renal sudden obstruction of urine flow, somebody with a very enlarged prostate who's suffering from a prostatitis, and the urine flow is stagnant, it's not flowing, it cause an injury to those kidneys. A kidney stone, Men suffer much more from kidney stones than females do, and it is a very, very painful, traumatic condition. And trying to pass a kidney stone, they'll do, they have a new ablation type treatment that they're doing at Goleta in the OR, and they go in for the prostate and do an ablation to open things up. And for the kidney stones, they do the lithotripsy. So there's like, excuse me, a lot of flushing. The bags that you do the irrigation with are bigger than the TPN bags. They're huge, and they go through 5 or 6 in one shift, just flushing and flushing out to make sure that no clots get stuck in that flow. A bladder tumor could definitely cause post-renal or an injury, like a blow to the kidneys. You sometimes hear football players having, renal failure because they've been hit in that area, like really, really hard, or even soccer players as well, kicked in that area. Polo is the one with the horses. They get hit with that stick. There's a lot of different things. And acute renal failure, it says, affects 15 to 20% of all critically ill patients, meaning critically ill, I would say patients that are, again, a trauma, a huge surgery. Critically ill patients has a 50 to 80% mortality rate. I mean, we need our kidneys. In acute renal failure, loss of kidney function is sudden because it's acute, with a rapid onset of hours to days. 50% of the nephrons are involved, and it could last 2 to 4 weeks, but usually less than 3 months. So meaning that a patient can get like a taste of the dialysis life, because it says if it can last, up to 3 months, they won't get a graft or a fistula put in their arm. They'll have a port put in to get their treatments. And when the kidney regains its normal function, or 80% at least, you would definitely know that they can take their line out and resume, their normal activities of daily living and not be tied to the regimen of being on dialysis. That's just a nice picture that I remember. I always drew that one so I could remember my kidneys. Causes of acute renal failure: hypovolemia, hypervolemia, hypotension, or your vessels, like a stenosis. So hypovolemia, gastrointestinal, that means you're not getting enough blood flow. Urinary blood or third spacing. So these patients with hypovolemia, they are dehydrated. And again, the third spacing means the fluid is not where it needs to be. For cirrhosis or heart failure, nephrotic syndrome, and IAH. Okay, hold on 1 second, you guys. 1 second, I'll be right. Intra-abdominal hypertension, that's a hypervolemia. Shock, true shock cardio, obstructive, distributive, like sepsis or hypovolemic shock. And then, a drug-induced hypotension, like somebody's taken something, a sedative or something, and they weren't able to get like a Narcan right away. That could cause definitely an acute renal failure. The decreased blood flow to the kidneys leading to an ischemia in those nephrons, or prolonged hypoperfusion. They need to be perfusing constantly, and lead to a tubular necrosis and an acute renal failure. Conditions that cause decreased cardiac output. So your heart's not functioning, shock, dehydration. And the biggest one I think here would be the cardiac arrest. Sepsis definitely will lead to a cardiac arrest, but these patients are really sick, very, very sick. Intrarenal is acute tissue damage of the kidney caused by inflammatory or immunologic processes from a prolonged hypoperfusion. And definitely if they're on a heart and lung machine for too long in a surgical procedure, this definitely can lead to an acute renal failure. The stenosis or thrombosis could be from a nephrotoxicity, taking something that was toxic to your kidneys. One of the girls that we took care of in the dialysis center, she was like, I think an 18-year-old that had some type of infection, and she was given sulfa. I think it might have been a bladder infection, and she was so severely allergic to it that it fried both her renal arteries, and she was on dialysis, and she was already like 23. So it had been already 5 years that she had been on dialysis and waiting for a transplant. I mean, it was super unfortunate because that was toxic to her. Her kidneys were allergic to that. So, I mean, I know many people that take sulfa drugs and have no problem, but when you see, that's why it's like so important when you're doing your checks. Have you ever, are you allergic to anything? I mean, that we ask that to every patient. We want to know, but an acute tubular necrosis would happen if there isn't that flow. And if you have necrosis where, it's a gangrenous area, a part that's dead, there's no flow there. Post-renal obstruction of the urine collecting system, that can happen, if there's a stone obstructing that area and the flow's not going through, you're going to get ischemic areas. Obstruction of the urine collecting system anywhere from the calces to the urethral meatus, urethral or bladder cancer, renal, ureteral or bladder stones, prostatic hypertrophy. And on one RT, you'll see a lot of gentlemen that go in with prostatic hypertrophy, and they go in and get that surgical procedure where they get reamed out, or they get a prostatectomy where they remove the prostate altogether. It can be very painful. It can be very bloody because it's very vascular. And then there's if there's a urethral stricture or an area where the flow, there's no flow there, that can definitely cause an ischemic area. 4 stages of acute renal failure. This is one to kind of understand very well. The onset for acute renal failure, gradual accumulation of the serum BUN and creatinine are noted. So they last for hours to several days. So you go in and you get, an H&H and a electrolyte panel done. I mean, that's a CBC and electrolytes is general. It's general in a urinalysis, and they notice that your BUN and creatinine are elevated. They're going to dig deeper. They're going to do more tests. The oliguria phase, characterized by urine output to 100 to 400 mLs in 24 hours, that does not respond to a fluid challenge or diuretic. So a patient may be in the oliguric stage, may be forced to take more fluids to see if, like, you get a patient that has a low urine output, oftentimes the physician will order a bolus to see if they can't get that patient to urinate. And then you bladder scan and say, oh, and still there's nothing in the bladder. There's still, or they'll get, some Lasix and a bolus and see if that helps. If that doesn't help, then there's further investigation. So labs are done, and a rising BUN and creatinine and potassium, the bicarb deficit, or they're becoming metabolic acidosis stage. And then hyperphosphatemia, hypocalcemia, hypermagnesemia, water retention occurs, and it could last 8 to 15 days or even longer in the older patients. So there's the diuretic phase where they have a high output phase. Usually it happens 2 to 4 weeks after the oliguric phase. So they're not passing urine, and then they get a very high output phase. The diuresis begins as the kidney gets better. So the BUN and creatinine and potassium and phosphate levels can stay elevated, and because they're not getting the clearance that they need. They may be losing the urine, but the kidney is not in full function, so they're not getting the clearance, because our kidneys clean our blood and get rid of the urine and the waste in the urine. So it could be just they're losing fluids, but they're not getting their clearance isn't going to be good. And then the recovery phase can be greater than a year for a full recovery. And some patients have varying degrees, and some patients don't get their full renal function back. It's 10 till. I will see you back at 10 and we'll talk about the chronic renal failure. So take 10. Gradual onset months and years. So if it's a gradual onset of months and years, you can think of a patient that's maybe in their 40s that has hypertension, has been diagnosed with hypertension, and perhaps is not taking their medications regularly, or they're taking it for a while, then they get off of it, they get back on it when they're not feeling so great. So if you say a gradual onset, it could be that a patient or a diabetic patient that's non-compliant sometimes follows, sometimes doesn't, goes back and forth with that. If you think of a patient like that, you could see where it could be a progressive injury to your kidney. So gradual onset months and years, 90 to 95% of the nephrons are involved. Once you lose the function, it's permanent and went fatal without transplantation or dialysis. So when a kidney function is too poor to sustain life, chronic renal failure is then deemed or termed end stage renal disease. Chronic renal failure, renal insufficiency, it can start very gradual. It can go over 20 or 30 years. So headaches, uh, decrease in the ability to concentrate urine. So you're maybe not getting the clearance that you need. Polyuria to oliguria. You have a lot of urine output to very little urine output. Your BUN and creatinine are elevated. You get edematous. Your glomerular filtration rate progressively decreases, or your GFR progressively decreases from 90 to 30 mLs a minute. You can suffer from a mild anemia, a slightly elevated potassium level, increased blood pressure, and weakness and fatigue. So this isn't going to just happen overnight. And some of your older patients will equate that to just old age. Oh, I don't pee as much as I used to, or I pee too much, or getting a little swollen. I got to put my feet up. They don't, maybe realize that the mild anemia is making them a little bit weak and fatigued. They're thinking, oh, it's just old age, and are kind of maybe putting this off. Um, the different stages, stage 1, 2, 3, 4, 5, where you get to the end stage renal disease. But this picture is it's such a good picture for me on the right, because it shows the stage 1 kidney damage with normal kidney function 90 or higher, and you're just looking like this little kidney shape 90 to 100%. You see a tiny little bit normal with mild loss at stage 2. Then a little bit more mild to moderate, stage 3A and 3B is moderate to severe loss of kidney function, so 44 to 30%. Severe loss of kidney function, 29 to 15, and stage 5 is kidney failure, less than 15%. This is a really good visual for me, but stage 1, diminished renal reserve, so patient is usually asymptomatic. Though 30 to 50% of the nephrons may be damaged, and the glomerular filtration rate is greater than 90. Stage 2, renal insufficiency, the patient has lost 75% of the nephron function, and the GFR is 60. Stage 3, GFR of 30, stage 4, GFR 15. And then when you're end stage renal disease, 90% of the nephrons are lost, you need dialysis or kidney transplant to survive. So a patient that's going to see a nephrologist and maybe they're at stage 1, they start with, a pretty, I don't want to say regimented treatment, but they start to get a patient ready. They start, the nephrologists that I worked for would say, you really should, they put them on a specific, let's say, antihypertensive medication, a mild diuretic like the AZT, HCTZ, hydrochlorothiazides, and try to kind of keep them at stage 1, keeping their kidneys functioning. And then as this chronic renal failure progresses, they go from a glomerular filtration rate of greater than 90 to the end stage where you need dialysis or a kidney transplant. And I would say it's usually around stage 3 that the patients start getting the nephrologists start getting them ready for a life like you're going to probably end up on dialysis. So let's get, your graft or your shunt ready, when we'll talk about that in a few slides. But medical management, early renal failure and renal insufficiency are treated with symptomatically with like a diet, medication, and careful monitoring. So restricted diet and fluids, the diet is very regimented if you look at this diet. Cereal, glass of milk, the fruit, maybe some fruit that's not high in potassium, a lunch, good combination of starch and proteins and fats, maybe an afternoon snack, a cornbread and a beef patty. I mean, all of these things, pretty dinner, a yeast roll, steamed chicken, squash, and margarine. Okay, that would be a restricted diet, and monitoring your oral intake. So a lot of the patients would get a large tumbler, fill it up with water for the day. And I see you guys filling up those water bottles every 5 minutes. You're just drinking water and it's so good for you. And these patients can't do that. So if they get 1 tumbler of water a day, they freeze it. And as it melts, they'll sip on that. Because a lot of times when you're restricted with something, it's human nature to just want more. So if they fill up their glass, they'll just chug that water because they can't get satiated, and then they're done for the day, and it's only 10 o'clock and you have all the rest of the day where you're thirsty all day. So that freezing the water, wrapped it with a paper towel, and as it sweats, as it melts, this water will generally last them for most of their day. They take their medications, which would probably be antihypertensives. They would take maybe a slight diuretic, that type of thing. And then careful monitoring. How are you feeling? Your labs are maybe monitoring. Later stages, again, dialysis and kidney transplant that we'll talk about. And that's a really tough life. This is the chronic kidney disease for you to review. It does have, like the teaching that I'll talk about really briefly right now. You want to be able to make sure that your patients are taking their medications on time. If they're smoking and the smoking is a vasoconstrictor, you want to see if you can help them with smoking cessation plans, or it would be a nicotine patch, the nicotine gum, or those cessation groups that they go to. Treating their hypertension is an important one, treating an anemia, and then their diet. It says, you want to talk to them about fluid restrictions, and the type of diet they should be on. And then dialysis, when indicated, you talk about the different steps there. And we're going to talk about that right now. But this is just a good picture. I like pictures. They're easier. Chronic renal failure. It says disturbance in the hematological function. So you'll see symptoms are going to be anemia. Normal hemoglobin, 12 to 17. Normal hematocrit 35 to 45, and these patients tend to be very low. So this epigen, or this erythropoietin that you'll see on your skills sheet that'll put in today that we talked about this is something that these patients, when they are losing the function of their kidney in the chronic renal failure, they can't build their erythropoietin, and they become anemic. When they become anemic, they get dizzy spells, they get chest pain, angina, can suffer from heart attacks, because you need those red blood cells to circulate and oxygenate. So the Epigen is the medication made by Amgen that they get subcutaneous. Remember, I told you, if you draw that up, one of those vials, and you are fortunate enough to give this medication, make sure you get every last drop. And it really has made a difference in these patients' lives. There's so many studies out there that they feel like they've gotten like a second wind. They can, when you're building your blood back up, you feel better, you feel stronger. It's a biologic response modifier, and it does definitely help build the blood. So please study that one. I don't believe that you'll be tested anywhere near that, but if you see erythropoietin or epigen ordered, it's generally for your dialysis patients or your chronic kidney failure patients. Disturbances in the electrolyte balance. You're going to see, like I said, you open up your patient's chart, and every color but normal is going to be all over that screen. Hyponatremia, decreased sodium, hyperkalemia, increased potassium, decreased calcium for hypocalcemia, and hyperphosphatemia, you have an increased phosphorus, having a patient in metabolic acidosis. And if you look at the normal ranges are right on the screen here. Effective chronic renal failure, those three, BUN, creatinine, potassium, are elevated, and then the sodium, bicarb, and pH are decreased. That's a good screen to remember. That's a good screen to know when you have dialysis patients or patients with chronic renal failure. Physiologic changes, inadequate carbohydrate metabolism, increased triglycerides, cardiovascular, hypertension, and hyperlipidemia for sure. Respiratory, these patients are fluid overloaded. They have difficulty breathing. For musculoskeletal, the bone density is decreased. So patients get, a lot of fractures secondary to the chronic renal failure. So if you're on one Wood license, you'll see a lot of patients like that. And then the pruritus, their skin gets very itchy, almost like if you go in the ocean and when you come out to dry and you have like that salty, residue on your skin. That's how these patients suffer. They suffer from that. The body lets this salty like residue out on the skin, and it's very itchy, causing patients to scratch a lot. So keeping them like cleaned and moisturized helps them from not scratching so much, having open sores, because they look like, they're just gashing at their skin most of the time, arms and legs. It's really, really unfortunate. It says renal failure is a multi-systems disease and it affects all areas. So body fluids, hematologic, cardiovascular, GI, neurologic, and musculoskeletal. You'll see the effects, and then the cause. It really does manifest in every area, multi-system disease. The one that you'll see a lot of, we'll see all of these, but cardiovascular and musculoskeletal, you'll see a lot of secondary effects because of it. Acute versus chronic is a good paper because I like to have them compared, but acute, it's sudden onset hours. 50% of the nephrons involved last a couple of weeks to a month or less than 3 months. Prognosis is good with supportive care. They get in, and high mortality in some situations. Chronic is a gradual onset, months to years. And generally you want to say months to years of non-compliance. But in the defense of these patients, the non-compliance could just be the not knowing. You're living your life and things start to break down as you get older and maybe not paying close attention. So 90 to 95% of the nephrons are involved. It's permanent and fatal without transplantation or dialysis. That's a rough one for sure. Oh gosh, I really wanted to play this today. Okay, so please watch acute versus chronic. And then the diet, again, patients would come to dialysis. There was 2 types of patients and not usually any in between, the ones that followed their diet to the T. And if you look at 9 o'clock, they had this, 11, they had their snack, lunch was here, 4 p.m. a plain tea and a very bland dinner. There were patients that came in with their Tupperwares with the sections and they ate specific things and they were fluid restricted. And then they would finish the dialysis with very little, ill effects and go to work. Those were my regimented patients. Then I'd have way on the other side of the spectrum, I would have the patient that would come in with a full pizza, thick crust, a big gulp of not just like soft drink, but of like the slush that's pure sugar, and just say, well, I'm coming to dialysis anyway, and they're going to pull the fluid off, so I'm going to eat what I want. So if you think about it, psychosocial wise, there is the person that is regimented and that knows that if they eat that stuff that patient in bed chair A is eating, they'll be sick, they won't go to work, they'll feel awful, but maybe they'll have a delicious pizza. This one guy used to get a pizza with cheese in the crust pizza. It was like 4 inches high and he'd eat the whole thing. Sometimes halfway through, he'd barf. He would just feel so bad, but he didn't care. And he'd do it every time, not just, or he'd go to a drive through and get hamburgers that were like 3 burgers stacked high and eat that with a big gulp. That's what he did. That's how he lived his life on dialysis. He said, if I have to do this 3 times a week, I am going to enjoy myself. But the other side of that, do you think he really did enjoy himself? I mean, he'd have to be on dialysis longer. He would cramp up so bad because we would be trying to pull the fluid off of him. He'd usually barf all over the place. It was rough, but it was just a lifestyle. I had 3 or 4 that were like that. And generally the rest of them were very compliant. And this renal diet chart on dialysis is what they would do. I mean, open up that Tupperware and it looked to me like, oh my God, like so brutal. Like a chicken breast that didn't have anything on it. Like it didn't even have salt. I know it didn't. It tasted awful. It had to. 4 grapes or 4 slices of apple. She had like toast, white toast, not wheat, white toast, cut in 4 in one section. I mean, it was just like the most bland looking meal that I've ever seen. And she ate it. She had no problem eating her lunch, finishing her dialysis session, and going to work. Well, the other guy, on the other hand, he had a lot of different ideas, but he used to come in and use drugs before he came. So he'd be kind of high and he'd have all this food and everything. And we'd have to tell him, you're going to come back in 2 days so overloaded, feeling so bad, but you were used all your drugs before you came to dialysis and we dialyzed them right out of your system. So you're kind of like wasting your drugs that you spend all your money on. Or it was just a hard thing. And I'll tell you, that one guy, he lived for a long time doing that. And our perfectly regimented patients, oftentimes would not. So who knows? I don't know what the answer to that is, but it was a rough life for him either way. And he was said, I'm going to enjoy myself. I don't care. What have I got to lose? I'm going to die from this anyway. And they're not going to give me a kidney because I am a drug abuser. I felt like saying, well, why don't you be a non-drug abuser so you can get a kidney? But he just wasn't going out that way. So interesting. You'll see all different walks of life. And sometimes it's because of the drug abuse that caused the kidney failure. So you'll see that, remember, in the screens prior where it said it could be drugs, it could be illicit drugs, or it could be drugs that were prescribed. So, it just depends. The renal diet, early protein restriction prevents some of the symptoms of chronic renal failure and may preserve the kidney function. Accumulation of waste products from protein metabolism is primarily cause of the uremia. So patients receiving hemodialysis need more protein because protein is lost in the hemodialysis. At least 1.15 grams of protein per kilogram a day. And protein is found in milk, meat, fish, and eggs. So there's that. And I know you can do a lot of good stuff with that, but not without salt. For me, that goes to the salt restrictions. So if I'm ever on dialysis, I'm going to have a hard time giving up the sodium. In uremic patients not receiving dialysis, sodium is limited to 1 to 3 grams daily. Dialysis patients get 3 to 4 because it gets dialyzed out. Some people don't like salt in their foods, but some people can't eat without salt. And I wonder if this picture has the Mrs. Dash on it. No, I don't see it. Advanced chronic renal failure patient to limit potassium intake 60 to 70 MEQs a day. So if you see here low in potassium fruits, you'll see apple, applesauce, and berries. You see some grapes. I mean, that little lady had everything cut out and measured so perfectly. The vegetables that are low in potassium are here. That doesn't look too bad. But then other foods, the almond milk, coffee, iced tea, these kind of things are low in potassium. So these are things that you would see little tiny baggies or little tiny portions of these things. And when a patient starts with the renal failure, like when they're in the midsection, like stage 2 or 3, they get referred to a dietitian, and the dietitians will work very closely in their medical team. So they have a physician, and he or she will, get them to a surgeon, refer them to a surgeon for their graft or their fistula, refer them to their social worker for the different types of medications that they're going to be on, and definitely get them a RD, a registered dietitian, to talk about all these things. There are ways to help. Um, High phosphorus foods, breads and cereals, vegetables, canned or dried beans, lima beans, dairy products, milk, cheese, ice cream, yogurt, and custard. But then in the other screen, it said milk was a protein. Meats, livers, and pizza. That one guy, I'm telling you, a full pizza with the cheese pouring out of every port of it. He'd eat the whole thing. Sometimes he didn't barf. Somebody was shaking their head all grossed out. It was gross. And then the snacks are here. What are high phosphorus foods? There's the dairies, the nuts, the dried beans, the bran cereals, and whole grains. And then beverages like cocoa, ale, beer, chocolate drinks, or dark cola drinks. And then low phosphorus foods would be fresh fruits like apples, berries, grapes, that kind of thing. Vegetables like cauliflower, carrots, cucumbers, celery, green beans, and broccoli. Popcorn and crackers, rice, cereal, sherbets. The sherbets that were better for them were the ones that were sugar free. So it was kind of hard. Coffee and tea without milk. So the low phosphorus diets were helpful, the foods and the charts. Uh, Increased calcium intake would be like, here are some different food ideas, but the calcitrol is that tablet that you guys probably have given your patients in the hospital. And here are some like 10 foods highest in calcium. So you have the clams, acorn, squash, okra, trout, black-eyed peas, the spinach, low-fat yogurt, grated Parmesan, skim milk, and firm tofu. I don't see any of those options that are very good, so it's kind of a bummer. Vitamins would be iron. They'll take iron, minerals, iron, calcium, vitamin D supplements, and a lot of times it's hard for them to take those. A renal diet increase calories because you lose calories. It's hard to build calories with the specific foods that you're allotted on that diet. We talk about the dialysis patients, dialysis and peritoneal dialysis, and you'll see both in the hospital. Just last week, our patient that was in the MICU had the peritoneal dialysis machine going while he was there. And we talk about both. Hemodialysis is one that you'll see in our area quite a bit because we've got 2 dialysis centers in Santa Barbara. There's the one for Cineas that's over there by the Foundation Clinic by the 154, and then the one on State Street, that's the Artificial Kidney Center, which pretty much has almost taken up that whole block. It had just started when I worked there many years ago, and it's really boomed. It's really a big place now, and they do everything there. Here it shows you the dialyzer. It talks about, the fistula or the graft, and then the peritoneal, the difference between one is heme, the other one is that fluid in the peritoneum. And I'll show you most definitely each type. For the dialysis, it's a procedure cleaning and filtering the blood. It's a kidney substitute. So if you see here on this screen right here where the dialyzer, this is got tiny fibrous tubes or little tubules that bathe, like the blood goes through the little tubules and it gets bathed with the dialysate. So it removes the nitrogenous waste products and maintains adequate fluid, electrolyte, and acid-base balance. And every patient's got their own dialyzer. And crazy when I worked there that expensive dialyzer, this part of the machine was thrown away every time they were dialyzed. And finally, companies invented and put together reuse filtration machines that you could take the patient's dialyzer and sterilize it and bring it back to the patient. And in the long run, it really did help the patient get less hemolysis, like the blood. Once it was almost like the dialyzer was conditioned, so it didn't have as much breakdown. And there were in the beginning a lot of infections, but they really have kind of mastered this procedure of reuse at the dialysis centers. Oh, I know the artificial kidney center, they would show you guys, they'd walk you through and show you their whole reuse system. So they have the dialyzer that's labeled, and it has to be checked by two people, almost like blood, so that nobody ever gets the wrong dialyzer. It's the filtered blood returning to the body after it goes through that dialyzer. And then you have the peritoneal dialysis, where the dialysate is going into the peritoneum. The catheter goes in, it puts the fluid in and pulls the fluid back out after it's been cleaned. So there's pros and cons to that. And I do like to see papers written on that, because there are definitely pros and cons to both. Dialysis procedure, patient's blood is filtered by osmosis and diffusion. Substances such as urea, creatinine, potassium, and water move from blood through a semi-permeable membrane to the dialysate and return back to the patient. So that's the dialyzer for hemodialysis. It's transporting the blood from the patient through that dialyzer, which you see, which you see right here, this dialyzer. It goes through the dialyzer, through the membrane filter, and then back to the patient. 4 to 6 hours, 3 times a week is what patients usually, that's a routine for a patient in renal failure that has no more function. But some patients, like that one gentleman, he sometimes would have to add a 4th day because he's so abusive to his body and to his, diet and everything, that he would get so fluid overloaded. And imagine, when we talked earlier about every system that is being affected, your vasculatures, your cardiac, everything is being affected, your neurological status, everything. So all that abuse that he was putting his body through was most definitely noticed while he was on dialysis. So oftentimes, like I talked about, my patient in bed, chair A, she was regimented. She didn't ever go over her. She usually was done in 4 hours on the nose. She came 3 times a week and didn't end up in the hospital with terrible crisis or exacerbation of renal failure. She was, I don't know if she's still, I imagine she's not alive now, because she was probably older, a lot older. It's been, almost 30 years. So yeah, probably not. But I think she did do right by herself, and she lived a pretty clean life with that. It might have been boring, and that's what the other guy said. I'm not living a boring life, but he enjoyed doing all that abuse to himself. But again, it showed when he sat down in that chair. So if you look here, the schematic is, it goes out of the patient, through the blood pump, through the dialyzer. It gets bathed by the semi-permeable membrane and returned back. Venous pressure, air trapped in the air detector, and clean blood goes back into the patient. After 3 to 4 hours, and it's warm. So oftentimes what would happen for the first set of patients that would come in at 5 in the morning, they would just get their pre-dialysis assessment, meaning blood pressure, weight, everything, see how they're doing, check all of that over, do a head to toe, get them in the chair. It was nice and warm in there, because we'd get there at 4 in the morning to get everything heated up and get the machines running. And the patient would get in their chair, recline it, put a warm blanket on, and go to sleep for those 3 hours, because it's a warm substance that's going through and bathing their blood. So they felt good. They felt warmed, they slept. And at the end of the procedure, we'd wake them up, we'd start waking them up, they get ready, and post, they'd have to stay another half hour to make sure that they were in stable condition. So you see the blood comes out, goes through the blood pump, through the dialyzer, it gets filtrated through here, and these 2 big jugs of fluid is the dialysate, and each patient had a different prescription. Then it would be returned back to the patient. Pretty tough life, I would say. Now it can be delivered through an arteriovenous fistula or an AV fistula, which is here. I don't know why it says hide. This is the patient's own, and we talk about that, or arteriovenous graft, which is an AV graft, which is here. And Also the central venous catheters that are put in, like a vas cath or a permacath, that are put in for temporary use. So let's go to the next one. Let's see if I have it here. The AV graft is a tube of synthetic material. It connects a vein and artery together. It can be used 14 days after insertion, and it lasts 3 to 5 years. So they get the synthetic material and they loop it from the vein and artery. It goes away and comes back clean, and it goes through here. And we'll talk about what happens, side effects to those as opposed to your own. So that's an AV graft. And then the fistula is a surgical anastomosis of an artery and a vein. So they take the artery and the vein. The venipuncture at a distal site removes the toxin laden blood from the patient's arterial circulation to the dialyzer, and the venipuncture at the proximal site returns the blood, clean blood, to the patient's venous circulation. So if you've ever felt one, it's like so aggressive and so loud. You feel this pressure just booming through this vein. The arms on these patients look really, really beat up, like pretty abused and scarred because they've had several. This fistula can be used 1 to 4 months after insertion. So if a patient is on maybe, I want to say the third stage, they will be sent to a surgeon and they will be counseled and talked to. They do a lot of the psychological training for the patients, talk to about, we're going to put the graft in. We may not need it right away, but it takes 1 to 4 months after the insertion. And they're preferred over grafts because they remain more patent, because of course it's human anatomy, and they are at less risk for a thrombosis or an infection. They were easier to access when you put those giant needles. Imagine those needles that we worked with the other day. They're like 5 times larger than that. They look like nails almost that we pop into these fistulas and grafts. And you go in it the same way we showed you with starting an IV, and you fish it right through, and you know right away if you get blood return because it's so strong. And it's like putting a needle into one of Jason's veins. No, one of Justin. It's like putting it into almost a garden hose. It's that big and easy to palpate and see. But the fistulas are, I want to say, you have to take better care of them. And we will talk about that right now. You have to really train the patient. A vas cath is also just a temporary. So those are usually right here, right in the upper chest, placed in the upper chest, and they're used for maybe a temporary while maybe a fistula or a graft is getting placed. Subclavian or jugular vein, a permacath is venous and arterial port placed in the subclavian or a jugular vein, and you'll see those on the patients. Advantages to hemodialysis. I feel like some of the advantages has temp access can be used immediately. There's no training or work on the part of the patient, which I don't agree with. Rapid removal of waste products and fluids, and they can eat more protein. Okay. Advantages too, I feel like for a patient that might not have the wherewithal to do a peritoneal dialysis on their own at home. And then disadvantages is dependence on a dialysis center. You are tied to that place. If you want to go on a vacation, you have to plan far in advance to be a guest at another dialysis center. You can't go like, say, I'm going to take a week off. You take a week off and you may die. Diet and fluid intake is very restricted, difficult to maintain a work schedule. When COVID hit, these patients, a lot of them that were still working were able to work from home and decided to remain working from home. I don't have dialysis, but I do like working from home. It's much easier, but there's pros and cons to that too. And then again, disadvantages, increased risk of blood loss. So the advantages, I would say again, here when you say in-center hemodialysis, it's effective removal of waste products. Care is given by trained professionals, regular contact with other patients. You kind of build a rapport with your other, I don't say classmates, but they were like care mates. They all had the same problems. Rapid correction of their electrolyte balance. There's no equipment to store at home. Treatment is usually only 3 times a week. Now you go over to peritoneal dialysis, which we're going to talk about again, but I'm going to do the disadvantages here. Vascular access and surgery is required for hemodialysis. Use of large needles, and that does hurt. Schedule inflexibility. You're there 3 times a week at the same time. If you miss a dialysis, you're in trouble. You may end up in the hospital. You have to get to that center 3 times a week. One of my friend's mother, who's very, she's 84 years old. She goes at 4 in the morning. I mean, we hate going out to school at, 7 or 8, but 4 in the morning when you're in your 80s and the weather's hard is really hard. And I mean, here where we live, it's not usually that hard, but some people live in the east and they still have to go out in the snow. Cramping is with ultrafiltration is really, really prevalent. They get really bad cramping, sometimes midway through or at the end of their treatment, that you have to treat with more fluid. So you're kind of defeating the purpose of pulling it off and putting it back on. It's really, the cramping was really hard to watch for these patients. And then the risk of infection in a tunneled catheter with these catheters, the temporary ones more so. I'm going to come back to the peritoneal dialysis in a second on this screen, but we're going to finish talking about the hemodialysis. Vital signs before dialysis, patients' weight and lab work prior to dialysis. The lab work is usually once a month unless they've had an acute phase and they were in the hospital. Patient doesn't have to fast or hold meds. They can take them, but oftentimes are instructed by the healthcare professionals to hold specific medications because they will get dialyzed right out. We inspect the skin graft or fistula for signs of infection. We palpate it for a thrill. Feel the thrill. I don't know who put that there. List of the bruit you'll feel, and then check for the circulation of the extremities. Wash the skin over the fistula graft and avoid puncturing the same site. They come 3 times. So we start at one end and we move up 3 times. And by the time you go to the 4th site, the first site that you started with has already healed. So you can see like little tracks on the fistula. After dialysis, we apply pressure, but not too constricting because then you could occlude it. For 2 to 4 hours there, you'll see those patients that are wrapped. We do their vital signs. Completely avoid at all time blood draws, blood pressure readings on the arm of the fistula or the graft. When those patients come into the hospital, you put a sign above the bed, no BP, lab, or IV in that site on that arm. And patients will tell you too, if you try to go for that arm, they're like, no, they're usually generally very protective. You teach these patients to avoid carrying heavy items. When you get your grocery bags out of the car and you put like 14 on one arm, that arm has to get left alone. You wear loose clothing on that side, usually a button-down shirt that's very large. Some of the patients got these special jackets that have a zipper that they can access their graft or fistula. Avoid sleeping on that arm, which would be, these patients are kind of trained to put their arm on a pillow so it doesn't, when you fall asleep, sometimes that doesn't happen, but avoid no blood pressure injections in the access arm. Wash the skin daily over the access, and then assess for a bruit every day. A patient may go home and say, you know what, my graft or my fistula is not working. I can feel nothing. And they'll come in and definitely have to go straight to outpatient and have surgery to have it, derooted or reamed or however you want to call it. You can tell I'm a plumber's wife. They go and deroot those things. And some of them will come in to the dialysis center and feel kind of like, I'm not sure, but let's try it. And you'll get like, no, you don't see any backflow. And it's like, sorry. And you'll see tearful patients. They'll be super upset. The hemodialysis patient's diet is usually very restricted again, and dialysis is spread out 2 to 3 times a week. So this is just repetitive talk. Peritoneal dialysis. I'm going to go back a few slides after we say dialysis is uses in the peritoneum, the semi-permeable membrane lining of the abdomen to filter the fluids, waste, and chemicals. The dialysate is instilled and drained from the abdominal cavity by a catheter. So let's go back a few here. There we go. Schedule flexibility is easier to travel. There's fewer risks of dialysis associated cramps. Clinic visits are 1 to 2 times a month. The patient and family are involved in the care. No needles, no need for needles or vascular access, steady state therapy, um, gentler ultrafiltration. Disadvantages are here. Permanent external catheter in the abdomen, body image problems. There are no days off. You do it every day. The biggest one I've seen when I worked at the dialysis center is the patients getting peritonitis, a risk for weight gain from glucose in the dialysate, and they have to store all that equipment and supply at home. They need, and the need for self-monitoring care. So let's go back to where we were. There are boxes and boxes of dialysate. These patients have to have an area sequestered off in their home that is sterilized and cleaned pre and post every time you access that peritoneum. It is, a fluid that goes in and that gets drained out. And what happens is, if you think about normal, regular, everyday people, not many people, especially in our area, have big places, big houses, big areas where they can just sequester an area in the house just for this type of treatment. Now, older couples in their 60s and 70s that are live with all their children gone, we would see a lot of that where patients would say, I want to try peritoneal dialysis. Their hands were still nimble, very flexible. They were able to do this on their own. And they felt like husband and wife could take care of each other with a treatment like this at home. They'd hook themselves up. They would do their dialysis every day, or they would do it at bedtime and wake up in the morning and disconnect. There's a lot of different ways that patients made it work. And they liked the fact that they didn't have to go get poked 3 times a week. The bag containing the solution would go in, and you see the little holes here. It would bathe that area, and then it would get drained right out. So they put the fluid in and clamp it for a certain amount of time, and then they would open up the drain and drain it out. Types of peritoneal dialysis, there's the CAPD and the CCPD. So continuous ambulatory peritoneal dialysis, 2,000 cc's of dialysis is instilled by gravity through a catheter. They can walk around with it. And the catheter is clamped for 4 to 6 hours. After this period of time, the catheter is unclamped and it's drained for 30 to 40 minutes. This is done 4 times a day. Now, some people are homebodies. They don't want to go out to a dialysis center, and they don't mind this, and they live their life like this. Continuous cyclic peritoneal dialysis, while a person sleeps 10 to 12 hours, they will put the machine on, and that seems to be like the one of choice. But others just do this. This is what they do all day. This is their job, so to speak. And intermittent peritoneal dialysis, some types of machines for CCPD, but treatments are periodical within several days between treatments. That depends on the stage of their failure and how much clearance they can get with it. So the videos that you watch later on, look at both of them and see what type of paper you want to write. Peritoneal dialysis advantages we talked about. You don't have to, minimal blood loss, no vascular device needed, no sudden shifts. They, able to remove the large molecules, able to maintain an independent lifestyle. But the disadvantages, extensive training is required. You can't just be willy-nilly about it. You have to be super regimented and take care of yourself. Self-regulated. The risk for peritonitis, that is the one that I saw when I worked at dialysis. The patients would come in and you knew right away how sick they were. They would get temperatures over 100, but like 102, 3, and 4, they'd be in the hospital with sepsis. They have to store tons of supplies. They would drop them off, and the boxes are like Amazon at Christmas, but every week. And their immediate access use is limited. So they can't go in and just, if the belly can't be used, they have to get a line put in and have a hemodialysis done. But these patients, I want to say at least 90% of them in this area that we took care of, they did beautifully. They were able to you know, take care of themselves. There were some things that would happen, like if one of the tubing got pushed in too far or migrated, they'd have to get, reassessed and flushed and see if that would work. But generally, they did take pretty good care of themselves in our area, the patients that were at the artificial kidney center. So that's kind of, all peritoneal dialysis patients would be placed in a private room when they're in the hospital. We monitor their blood pressure, assess for edema, assess for signs of dehydration because they could be draining too much fluid off. Assess exit site for drainage, tenderness, and inflammation. Dressing changes are appropriate for that site. Strict INO still, and diet is less restricted because they're receiving continuous dialysis. So it's like they're like everyone else urinating and stooling all day long like anybody else would be doing. But because of protein loss across the peritoneum, they do have to watch that. Nursing care during peritoneal dialysis, vital signs pre and Q30 during, weight, lab, of course, continue the client for any respiratory distress, which would definitely come from fluid overload, pain or discomfort, monitor prescribed dwell time and initiate outflow. So that means how much time the fluid stays in as to how long it drains out. So observe outflow amount and pattern of fluid, like how it looks. Oftentimes that has to get checked and sent to the lab. Peritonitis is the worst complication, I think, of that type of dialysis. They can get a hernia because of the intrusion of the tube. It could stretch or tear that internal lining and cause a hernia. Exit site infection, or again, the migration of the catheter to where it went in too far and has to be removed or just moved around and x-rayed to make sure it's in the right place. Symptoms of peritonitis would be extreme thirst, fatigue, constipation, diarrhea, nausea, vomiting, bloating, fever, a low urine output, or the inability to pass gas. So that would be like an obstruction. So those would be symptoms that could be life-threatening. The transplant of these, guys, it's already 10 till, we're almost done. We'll talk a few more minutes and I'll give you another 10. Kidney transplants. Before, when I worked at the center, the patients all wore beepers. That's how long ago it's been. Nobody had a cell phone then. Patients are now, there's an app that has them connected to a transplantation center. And if they're on a list for a transplant, they have their phone with them at every moment and have it charged at every moment and have an extra charger because it is definitely a matter of life and death for them. The donor kidney it's harder on that patient because they have to go in deep to get that kidney. And the transplanted kidney is more superficial, so they don't have to go as deep. So both patients have a rough time, but if you can donate, it's really a lifesaver for somebody. We talk about that a little bit. 20 million people live with chronic kidney disease. 600,000 people are on dialysis. I have to update that because I know it has to be more. More than 100,000 patients currently awaiting deceased or cadaver kidney transplants. And then this is a 2018, 16,000 kidneys were transplanted in 2018. They are very successful. A 1-year graft survival rate, 90% for cadavers and 95% for live donor transplants. You'll get into, there's a lot of controversy about family donations of donor transplants. And some people in the class, when we had the class, we'd talk back and forth in the area and say, well, would you donate your kidney? And one person said, absolutely, I would give my kidney to my brother, to my mother, to my sister if they needed it. Do you have children? I do. What if your kids needed your kidney? You'd only have that one to give, or how would you figure that out? And they think about it back and forth, saying that one person stood up and said, I have a sister that is on dialysis, that's in, she's been on dialysis for about 14 years. She is non-compliant with her diabetes. She has been since she was, type 1 since she was a young girl. She's always been non-compliant. And I wouldn't give her my kidney because I have 3 daughters and I know her condition is hereditary. And I will save my kidney for one of my kids because giving a kidney to my sister, she would definitely be non-compliant. And I was like, okay. And people were like, wow, that's pretty heartless and going back and forth on that. But I'm giving you 10 more minutes because I have to be diligent on that. So I'll see you in 10. See you at 11 o'clock.
Linda, can I ask you a question?
Million people live with disease. So it is successful. I worked at the, what is it, Ronald Reagan UCLA and watched, they did transplants there every single day and more so on holiday weekends for the cadaver, the cadaver transplants. The thing with that is, um, patients have to kind of be close to wherever they hope to get a transplant. So it's kind of hard on people from Santa Barbara because the traffic on the weekends, how it is. And if you get called in, you have like such a small window of time to be able to go be the recipient of your kidney. So there's all these different things that, I don't know, come into play for these patients. It's a really hard life, I have to say. And for the most part, I want to say the people treated the dialysis patients treated it like they were, it was a family, it was part of their, social world. And when, excuse me, there was an empty chair in a regular treatment session, they'd be like, where is so and so? Either they were in the hospital, they were in Los Angeles getting transplanted, or they passed away. So it was really, a lot of pros and cons. You get very attached to these patients. And this kind of just shows you the transplanted kidney right beside the iliac crest and symphysis pubis right in the center. The patients that donate the kidneys have a kind of a tough recovery too, because it is very, it's way behind the organ. So yeah, they have to go in deep. Complications, rejection, and that comes into play for students and nurses when you're taking care of a patient. You want to make sure that you're not a cause of any rejection. So you want to make sure that you give them their anti-rejection medications on time, no matter what. They have to get their anti-rejection medication. And it has happened that public health nurses used to have to go and find patients that weren't, living in, that became homeless after they were already transplanted to make sure that they had their anti-rejection meds. And when you're getting screened for transplantation, you have to go through so much screening that discusses what your home life is going to be like, what your support system is going to be like, because they don't want to just transplant a patient that isn't going to be able to take care of it. And who's to say that, these patients get transplanted and later on down the line, they fall on hard times and become homeless. So post kidney transplant rejections, hyperacute onset within 48 hours, malaise, high fever, graft tenderness, organ must be removed to decrease the signs and symptoms. And acute would be 1 week to 2 years, oliguria, anuria, increased temp, increased blood pressure, flank pain, lethargy, increased lab, like the BUN, potassium, and creatinine start to increase and they start to retain fluids. So, and chronic gradually over months to years, an increase in the BUN and creatinine, and imbalance in their electrolytes, and they become fatigued. So they could be just slowly rejecting it, like chronically, or hyperacute, or just acute rejecting a kidney. Infection, most common infections are observed in the first month, like a pneumonia, a wound infection, an IV line or drain infection. So you're super careful with IV lines and drains. Recurrence of the original disease, and then a corticosteroid related complications could also, have a patient reject their kidneys. Cardiovascular disease, transplant recipients have increased incidence of arteriosclerotic vascular disease, uh, immunosuppressant can worsen hypertension, hyperlipidemia, adhere to the hypertensive regimen, and sometimes that's hard to do. Malignancies, screening is important for care to make sure that they don't get a kidney that could have, you know, a type of a cancer cell that could harm them. And then you see over here the complications, hematoma or seroma, graft infection or abscess, a lymphocele, urinoma, vascular complications, urologic complications, diminished renal function, or a mass lesion. It says post-transplant lymphoproliferative disease or an inflammatory myofibroblastic tumor. That can happen, and they're not able to see that when the kidney is transplanted. So if they do get a live donor and something like that happens, that person that is the donor could also be, you know, at risk for losing the kidney that they do have. So it's a whole big workup. In immunosuppression, there's an assessment. You assess for signs and symptom of rejection, like, you know, malaise, fever, edema, pain over the transplant site, increase in weight because you're filling up with fluids. There's several different things to look at. There's diagnosis and planning and intervention. But when you are taking care of a patient, all of these kind of things should come into play for you when you're planning your care. You're assessing, you're diagnosing, you're planning intervention. You're going to talk about to instruct a transplant patient on the benefits of balanced and healthy diet and exercise. I mean, once a patient has been given this like new lease, it's so important to do the education that comes with it. And they have to attend like weekly at first and monthly meetings, and they have to drive out of town and they have to commit to it, because it's just something that will help them restore and prevail with this condition, with this new lifestyle, taking care of their transplant, monitoring their blood pressure, checking for any signs and symptoms of infections. So it is one of those things that if you get a patient in the hospital, we don't do transplants here in Santa Barbara, but you will get patients that have been previously transplanted and you're going to take care of them. It's so important to go through the steps and talk to them about, you know, there are different plans of care for them. You want to make sure, for one thing that I do know for sure, is you want to make sure that these patients most definitely take their anti-rejection medication on time. They take all their medications at the same time every day, you know, medication boxes and everything. And people say, oh, but they just got, you know, a new kidney. Don't they have a new life, you know, a new chance, a new life, all of that. But yes, they do, but they still have to take care of it. They have to take care of it. And the pros and cons to that are, do I want to lose this kidney and go back on dialysis? Or am I going to be, you know, taking my meds every day is nothing compared to what I've already been through. You know, it's kind of one of those type of things. So you just want to know that these patients get a lot, they get a lot of counseling, a lot of support. And it is really important to not only, you know, not only take care of what they have, but to really try very hard to stay on a schedule and to be regimented with their care for themselves, because they definitely have to advocate for themselves. They have to take care of themselves. They're not part of that community. I mean, they go weekly at first, monthly, but they're not part of that daily community where they're being supported. So thinking of that, I mean, there are, again, I want you guys to look into what you're going to write about, and hopefully what you write about will help you learn about the process, so that when you take your exam, it helps you and it's not just busy work. Because again, we don't get to go to the dialysis center, and I think it's kind of unfortunate. I think maybe by next spring, a year from now, we'll be able to get back into our dialysis clinical day. It's one day, it's an 8-hour day, but it does count for that paper and help you. Just give like a little paragraph write up on what you did and what you thought of it. Some days they're nice and some days they're not. So it's just depending, but I had pretty much like a 90% success rate at the dialysis center. So hopefully that comes back, but I don't want to give another break because I want to get through this, and there's not many slides for PEDS. So if you want to go take a quick bathroom break, we'll take 5 minutes and then we'll start our PEDS and finish it up, and you guys will be free for the week. So 5 minutes gives you a second of nurses and the muscular dystrophies as well. But the cerebral palsy patients, they're, I think 3 or 4 of them are in their teens already, and they come in usually with pneumonias or flus like symptoms, that kind of stuff that brings them in, or aspirate pneumonias, that kind of stuff. Pediatric differences in the neurosensory system, the size and structure. So rapid head growth in early childhood, their bones are not fused until 18 to 24 months. The autonomic nervous system is intact. Neurons are completely myelinated by a year. Infant behavior initially reflexive, but are replaced with purposeful movement by a year. And then infants demonstrate a dominance of their flexor muscles. Motor development occurs constantly in the head and toe progression. And I know you did this in your growth and development charts, but just kind of refresh your memory because it's going to be different going to PEDS. It is different. And you have to remember to like age, size, structure, what goes on. For bacterial meningitis, that's obviously going to be a patient that's going to be in isolation. The central nervous system is causing inflammation of the meninges and spinal cord, causing, rigidity, nuchal rigidity, photophobia, joint pain, malaise, purpura rash, Koenig's and Brudinsky signs. And generally, these patients will be seen in the ER, and even with just one of these symptoms, usually it's the rigidity, they will get tapped. They'll get a spinal tap, a lumbar puncture, and they will get diagnosed right away. It can happen at any age, but usually between 1 month and 5 years. So imagine the 1 month to 5 years where these patients are, these families are just devastated by this. First of all, if any of you work in the ER, I know you've seen a baby get tapped, and it is very traumatic for the baby. They give them a sedation usually, but for the family that's there, the parents or the caregivers, it is really, really difficult to watch. Most common sequence, hearing or visual impairment, seizures, and cognitive changes. And oftentimes they don't try to sedate the babies or the infant, the child, because they want to get a baseline of what's going on. They get the lumbar puncture, the cerebral spinal fluid is cloudy with increased WBCs. So there could be a bacterial or a viral infection, increased protein, low glucose, and the patients are very sick. I mean, they put in IV antibiotics and meds, and decreasing the intracranial pressure is the main, objective. These are just the Brudinskys and the Koenig signs, and I know we've looked at those before. They check to see if those are not, these babies or children are not flexible. Meninges is the inflammation of the lining around the brain and spinal cord, and it is usually caused by an infection. It could be a septic or an aseptic. It could be secondary to a bleed. If they had a bleed in the brain and that fluid around the brain went into the spinal column, it could be, once they do the tap, you could see maybe tea-colored fluid coming out, and they will definitely be cautious. It can be bacterial meningitis is contagious. Germs can cause it to be passed from one person to another through coughing, sneezing, droplet, or through close contact. So it is a droplet. Most common symptoms, again, fever, trouble staying awake, a headache, vomiting. Seizures are the scariest, especially for new parents. Stiff and painful neck. I mean, if you've been around a baby or a child, they're just like rubber balls. You can bend them any which way, especially if you try to touch the chest or the chin and it's painful to move that neck, then that child generally needs to get to the emergency room right away. Children and older adults and people with other medical problems may have different symptoms, but babies, they get cranky, they don't want to eat, they could have a rash, and it's usually a truncal rash. They may cry when they're held. Usually a kid stops crying when you hold them, but everything hurts. And an older adult with other medical problems, they may have like a slight headache or fever, but one key symptom would be they're very photophobic. Like they can't stand the sunlight, or they have to have sunglasses on to go outside or to go into another room because the light is really bothers their eyes. A Reye syndrome is a pediatric emergency. Cerebral complications that may reach an irreversible state. Vomiting, change in level of consciousness to coma, an acute encephalopathy with fatty degeneration of the liver causing fluid and electrolyte imbalance. Metabolic acidosis, hypoglycemia. So remember, acidosis, hypoglycemia, dehydration, and coagulopathies. Most frequently seen in children that are recovering from a viral illness and that were given aspirins like salicylates, that's right, were given. So aspirins were given. Therapeutic management is intensive nursing care and, excuse me, adequate cerebral perfusion and an increase in intracranial pressure. Increased ICP secondary to the edema, that's cerebral edema, and is a major contributing factor to the morbidity and mortality of these patients. So a child coming in with Reye syndrome, change in their level of consciousness to a coma, the first and foremost thing they're going to do is try to decrease that intracranial pressure. They're going to get the tissue perfusing again and try to decrease that pressure. It could be with putting in a drain, it could be with different medications, but it's definitely something that is an emergent situation. It's progressive encephalopathy with hepatic dysfunction. It could be because of the aspirin that's been given. They could have had influenza A or B. Other risks, inborn errors of metabolism. So the metabolic chain of the acyl coenzyme A dehydrogenase, or the MCAD deficiency, and other fatty acid oxidation disorders. So urea cycle disorders could cause a Reye syndrome. Several days after recovery, they have fulminant hepatitis, cerebral edema, altered levels of consciousness, and the behavioral changes. So with that cerebral edema, again, a main objective is to get the intracranial pressure decreased. That is like the main objective for these patients, and to get them perfusing properly. The liver damage can be stages of that encephalopathy, like brain dysfunction from increased edema and increased pressure. Stages of the encephalopathy could be quiet and sleepy with vomiting. The stupor, meaning like they're listless, they're not able to respond correctly. Maybe coma or decerebrate response, where you see those reflexes. There's no pupillary reflex, and then coma, no deep tendon reflexes, and then they could die. Inflammation, swelling, and edema buildup in the brain is what they're looking at. From ages 4 to 12, and generally it is after a viral infection that was treated and aspirin was given. You don't hardly ever see any children being prescribed aspirin for any reason. So some kids with coagulation problems may be on a tiny amount of baby aspirin, but that's a whole different condition. But for any kind of illnesses in the old days when we were kids, it was baby aspirin. There wasn't Tylenol and Motrin that were given for fevers and whatnot. So I'm sure there was a lot more Reye syndrome then. I have never seen any child in the hospital here in our area with Reye syndrome, but that doesn't mean there aren't any. Seizures, we talk about febrile seizures, meaning an increased elevation of their temperature above 102, and it's caused by a rapid elevation of a temp. So if a kid has maybe, let's say, an ear infection or a bladder infection, they can get a very high temperature causing a seizure. Scary. I've seen it on a child before. It's very scary. Cooling them down and getting them out of that state is really like something that you need to do immediately. Most children don't have second febrile seizures, and it's usually only about 3% of them would then down the road develop the epilepsy. Focuses on the care of the patient. And the first and foremost is to get that fever down. What's the cause of the fever? Is it an infection? We give them something to get the fever down and then educate that patient's family or parents what to do after that. Remember basic CPR during seizures, airway and oxygen. We don't put anything in their mouths anymore. We put them on their sides with their heads up a tiny bit so they don't aspirate. We have seizure precautions at the bedside would be suction, oxygen, and then the padded rails so they don't hurt themselves. It says infants often have a subtle seizure with only ocular movements or some extremities, but it is repetition. It does go like constant until the seizure passes. It's very, very scary. It's a very scary thing to watch. And some parents that have kids that suffer from epilepsy, if they don't take their GABAs on time or the right amount, or they're not monitored as the child is growing, they can have, a seizure, and it's pretty scary stuff. There's the generalized seizure produced by the entire brain and the symptoms. So a grand mal, your unconsciousness, convulsions, and muscle rigidity. Those are the kind that you can kind of never forget watching. So they're really quite scary. Absence seizures are just a brief loss of consciousness. Then the myoclonic, sporadic jerking movements. Clonic is repetitive jerking movements. Then tonic, muscle stiffness and rigidity. And atonic, just the loss of muscle tone where they would become limp. Partial seizures or simple awareness is retained to where you kind of get vague for a moment. Simple motor, jerking, muscle rigidity, spasm, and head turning. Some parents are so used to that with their kids that have epilepsy and chronic seizures that they'll kind of just hold them to the side while they go through it or set them down so that they don't hurt themselves. Simple sensory unusual sensations affecting either vision, hearing, smell, taste, or touch. And these are just partials. Simple psychological, memory, or like an emotional disturbance. And then complex, it says impairment of awareness. So automaticism, such as lip smacking, chewing, fidgeting, or walking, and other repetitions. So they'll do something like kind of a sporadic thing that they wouldn't normally do, involuntary but coordinated movements. And then the partial seizure or secondary generalization symptoms are initially associated with a preservation of consciousness that then evolves into the loss of consciousness and convulsions. And I don't know if anybody's heard of the dogs that are trained to be able to know if a seizure is coming on. That's a pretty skilled dog, I would say. I can't remember what movie that was, but they can kind of feel the aura that's coming on, and they kind of help their person like put themselves down to the ground or get ready to know that a seizure is coming. It says, although seizures can be frightening, many last only a few minutes, stop on their own, and are almost never life-threatening. Seizures can take many different forms, and you see all the different types. It says forms staring spells into involuntary movements of arms and legs. And again, signs and symptoms are different, what to do. I feel like when we're in the hospital and we know that they are at risk for seizure, we do seizure precautions. Any of the neuro patients will have seizure precautions, meaning the bed's padded, they have suction, oxygen, and the definite padding and safety measures are put in place for these patients because you don't want them to harm themselves during a seizure. I don't know if anybody's ever witnessed a seizure. If anybody wants to share one, I have. They're scary. They pass pretty quickly, but I have had students that have been super traumatized by watching grand mal seizure happen to one of their patients. So has anybody here seen a seizure while they've been in clinical at all? Mm-mm. Well, if you have seen one and you don't want to share, I understand that, but multiply it times a lot when it happens to a child. It's really quite scary for everybody involved. We talk about a hydrocephalus. It develops as a result of the imbalance of the production of the absorption of the cerebral spinal fluid. So it's increased fluid in the ventricular pressure leading to a dilation of the ventricles and pressing on the skull. It would be an increased intracranial pressure. So poor feeding, vomiting. You'll see the fontanelles that haven't fused yet. You'll see them bulging, the head enlargement, separation of the sutures. You know, in the back, you can see they're kind of moving because the head is large and the brain needs a place to go. Lethargy, irritability, restlessness, not responsive to parents. The child could have a headache, vomiting, diplopia, ataxia, a papilledema, and then, of course, the seizures that we were just talking about. So you see here the normal ventricles, and then somebody that's got the hydrocephalus. So in A patient, patent cerebral fluid circulation, but B, it's enlarged here. And you can see where the ventricles are having an obstruction of the circulation. So stenosis of the aqueduct of Sylvius is, you know, narrowed and not letting it flow. It's pretty prevalent. You would do, and I want to say it's every 4 hours they measure. They do measure with kids that have hydrocephalus. Normal pressure hydrocephalus would be gradual accumulation of the cerebral spinal fluid where a shunt is put in. And I show you a picture. This is kind of a silly picture, but I'm going to go to the picture that you can see. The shunt is put into the brain and it's kind of weaved down, and the cerebral spinal fluid that accumulates will then shunt to the abdomen, and it goes into the abdomen and it's reabsorbed. So you would have relief of the hydrocephalus. It's prevention and treatment of the complications, but the intervention is you put the VP shunt in, ventriculoperitoneal shunt, and the one-way pressure valve releases the fluid into the peritoneal cavity where it's reabsorbed. Now, things with that, kids grow quickly, so they have several surgeries. They sometimes can move. They are threaded beneath the skin, but they can sometimes move, or they could get, you know, a kink in the tubing that's in the peritoneal here, and you get extra tubing here that will kind of allow for growth, but it is underneath the skin. And if you feel the side of the patient's head, you can feel the tubing because it is quite superficial, but it is put into that ventricle and it's behind the ear. It weaves down. And for girls, it's not as bad because they generally have the longer hair. But for boys, oftentimes you'll see that they shave that area of the head so that they can kind of keep track and see what they're, you know, monitor it closely. And one little guy that we had at cottage said, I already told my mom and dad, he was 6 years old, I'm growing out my hair and I'm going to get a braid all the way to my butt. And I was like, whoa, that's a long braid. He's all, yep, I'm going to get a braid. I don't want everybody to see my business. So if I braid my hair on one side, I can put it around my ear and have it go down. I thought, pretty smart kid. He wanted to keep his shunt out of sight for people, because a lot of times these kids, it's when they go to school, they do have to have, and not a person, a worker with them every minute, but they do have a nurse on site or a worker around that kind of regulates kids that have this kind of thing. You see here the extra tubing here, and it says it's for growth, because instead of having to have surgery again, they would just leave room for it to grow a little bit. The head circumference, occipital-frontal circumference is measured, and you have those non-invasive caps that monitor the size. But when they're in the hospital, oftentimes it's just a little tape that you saw in lab the other day that you measure the baby's head with when they're born. Just the paper tapes, we measure them and chart them. And it'll be interesting to see if any of you get a patient that has hydrocephalus. That it may not, the child may not be in the hospital for that, but it could be for a shunt replacement or, you know, a minor surgery like that. So nursing interventions for any neurological dysfunction, monitor the neurostatus. So we're going to determine a baseline. We're going to assess their level of consciousness, assess motor sensory, pupil checks, vital signs. The head circumference is the big one because if fluid is backing up, it will definitely show right away. These patients always have seizure precautions, meaning what? You have suction and oxygen at the bedside. You have their beds padded. There's fall precautions. It could be restraints, meaning that for some of them, they might have to wear the cone so they can't reach. They can't reach and pull or poke at their graft that's in their head. Determine their level of consciousness. That's how you can monitor and make sure that they're safe. Cluster care, meaning decrease the times of in and out of the room. You know, you want to make sure if you're going in to do something, do as much as you can just to decrease the stress of that child. Coming in and out could get them all worked up again. Your initial, perhaps your initial assessment, you'd walk in and they'd feel stress. They're feeling stressed out and like in a panic. Well,
I didn't get that. Could you try again?
Oh Siri, that silly watch. Cluster care decreases the stress for the patient, definitely. And keeping a quiet environment. The head of the bed is up 30 to 45 degrees, appropriate position. So head is midline, no hip flexion or prone. Medications would be the pain meds, corticosteroids, the diuretics, soft stool. And why would that be? We don't want them to strain. So you want a stool softener, anti-infectives, no infections, and then of course the anticonvulsants that you'd be in charge of. Maintaining adequate cerebral perfusion, so maintaining their airway, making sure their oxygen saturation is where it needs to be. They might need to be, they're on a pulse ox, but they might need to have a little oxygen as a supplement. Monitor their temperature and antipyretics if they need them, if they need some Tylenol or Motrin, keep a temperature down. And then maintain normal volemia, making sure that they are adequate with their I's and O's, what's coming in is going out. Assess their perfusion, making sure that you would check their tissue perfusion, doing their blanching of their fingertips and toes, nutritional and fluid needs, determine swallowability prior to giving them oral medications. NG tube feedings may be necessary. They get a registered dietitian, PRN, to speak with the families and make sure if the kids are old enough to talk about what they like to eat and what they will eat. We do daily weights and sometimes shift weights, monitor their labs. We have the child life consultant. She comes in a lot and does a lot of teaching. And sometimes the psychologist will come in as well and talk to the kids. Autism is pretty big right now. There's so many people that are on the spectrum, and I wouldn't say that you're going to take care of somebody in the hospital because they are autistic, but secondary to that, they could come in with something different. You know, let's say they came in with a flu, a COVID, an appendectomy, a tonsillectomy, and they have autism to add to the mix. Is a severe developmental disorder of varying degrees. So it's on a spectrum. It could be from very mild to very severe. The etiology is unknown. Social interaction can be a problem, language and behavior, lack of interest in human contact, decreased stimulation, minimal holding and eye contact, poor nutrition, very fussy eating habits, food refusal and mouthing objects, throwing food. So maximum potential for ST, PT, and OT, speech therapy, physical therapy, and occupational therapy. But the reason that this is talked about in pediatrics is taking care of a patient that has autism and you're in with, again, let's say API. It's going to be a lot different. Your plan of care for this patient, your plan of care to work with the family. The family knows best. Usually the caregivers or family know best as to what is the best plan of care for the patient. So with that, keeping that in mind, you generally will want to understand and figure out what the best interaction with the patient will be, because going in, full bore with your plan and your time grid is not going to work usually. So watch these videos and understand that there can be different types, characteristics of the spectrum, autism spectrum disorder. You have the different types, things that the children will do, and examples. So I'll give just this one, the echolalia. Children repeat what has been said to them either immediately or after some period of time. So a parent said, do you want to drink? The child will say, do you want to drink? A child with ASD will repeat the question instead of providing an answer. Just different things to look at. And it's not, necessarily like I say, you're going to take care of a kid because they're newly diagnosed with autism in an acute care setting. But if this is added to your diagnosis, you're going to want to look at it and find ways of helping get points across, get plans of care across, and figure out ways that will work best for this child that you're taking care of. Signs and symptoms of autism spectrum disorder include, all of these: display of lack of interest in others, have difficulty relating to them. It says absence of joint attention, the shared focus of two people on one object, avoid eye contact, fail to point out objects to convey interest, or fail to look at objects when others point them out. They prefer being alone. They do not empathize. They have difficulty conveying personal needs and desires. Exhibit unusual responses to sights, smells, tastes, textures, and sounds. Do not engage in pretend play. They prefer not to be touched or to be touched only on their terms. So that's one to think about as a healthcare provider. They don't want to be touched. So it's sometimes very difficult to do an assessment. And you may need two people to do the assessment with you. They appear unaware of others and that address him or her, or hyper attentive to other sounds. They fail to initiate play or interaction. They repeat or echo words, phrases. They repeat phrases in a place of a normal language. Displays restricted repetitive actions. They have difficulty navigating through routine changes. Again, that's something that needs to be pointed out to the healthcare provider. Exhibit loss of skills previously attained, so they can regress depending on, the severity of their condition. ADHD is attention deficit hypersensitivity disorder. So, hyperactivity disorder. So they are not only on the spectrum, but they also have, a lot of impulsiveness. They're very hyperactive. So often these children do have workers with them. It says developmentally inappropriate degrees of inattention, impulsiveness, and hyperactivity before the age of 7. Present in 2 settings. So behavioral therapy, family therapy, reward contracts. A lot of times, one of the videos that you're going to watch has, a lot of examples of how the reward contracts work with these kids. And you can kind of, if you have one of these patients, you can kind of work with the contract too. And the nurses generally will have something set up because they're very used to this. They do use them for strategies for success at school. But as far as reward contracts in the hospital setting, it is, we're going to do all these things. And then after we're done with all these things, we're going to go play. Not, if you do this, you get to go play. It's kind of like a different speak that you give this type of child. We have X, Y, and Z to do, maybe a bath, maybe a medication administration and a dressing change. And as soon as we're done with that, we're going to go to the playroom. You and I are going to go to the playroom, and your mother or your father or your uncle can come with us, and we can look at a few new things that we have. So it's not necessarily saying if you do this, you get that. That's what our plan is for the day. But we only are doing this if we do that. So it's kind of tricky speak. Stimulants that are given would be the Ritalin, the Dexedrine, the Concerta, Adderall, tricyclic antidepressants, the Tofranil, and then non-stimulants would be the Strattera. There are a lot of different cocktails that are given to patients, and I truly do feel for the families or the caregivers. My brother takes care of my sister, my sister that died, one of her sons, and he is on the spectrum, and it's been, a long haul. He's 19 years old now, but he is very impulsive. He's really, really bright, but he doesn't know how to express himself. And he's very literal. He speaks in a very literal sense. He doesn't have any filters at all. So that's kind of rough. That's kind of rough to be with this young man, but nice looking, beautiful kid. It's just very unfortunate. ADHD nursing considerations, you follow a treatment plan. So here it says, be sure they get what's best. So where have we been? It says almost 1 to 2 preschool children have ADHD and got no therapy. 1 in 4 were treated only with medication. We need to provide behavioral therapy first before medication. So there's all these different schools of thought. This one is from the CDC. And depending on where the parents are, some will just absolutely 100% refuse medication for their children. I don't feel that I need to medicate my child to live in this world. The world has to accommodate them. And, there are definitely 2 sides to every story, and people don't feel like medications. They don't know what the long run's going to turn into. So there are a lot of things that you would see, as far as different plans of care, parenting strategies that work, sometimes provide positive attention, give effective instructions, praise the child for their effort, establish rewards, and then use consistent consequences for behavior. And does that always work? Like they said, how much is retained? So it could work for that day and start all over the next day. We have to start all over. So how do you feel like these poor parents must feel as far as their frustration level? Impulsive symptoms and ADHD inattention symptoms. So here's just criteria for the diagnosis: fidget with hands, leave seats in the classroom or situations where sitting is expected. They run about or climb excessively and inappropriately. I mean, all of these things are just examples. It doesn't mean that every single one of them is going to be for every single child, but blurt out an answer even before the question is completed. And then inattentive symptoms could be they don't seem to listen, they don't follow through, they have difficulty organizing a task, easily distracted, all of these things. And my heart is very empathetic to teachers of small children that have a group of maybe 10 or 20 kids. I don't know how many kids are in classrooms now, but that have a child that is constantly interrupting or, distracting other kids, or just causing a disruption in the lesson plan, to where they definitely do need a worker that can kind of reel them back in. And they don't need to be isolated. They need to be integrated into classrooms and learn skills, coping skills. But it's very difficult, I imagine, on the aide and on the teacher. And coming back into the classroom after the pandemic has been probably a real, adjustment for these kids. It says boys and girls display very different ADHD symptoms. So boys more impulsive, girls more withdrawn, low self-esteem for the girls and anxiety, hyperactivity, such as running and hitting for the boys. I mean, it goes back and forth. And again, just a generalization. The symptoms could cross over back and forth. Hard to take care of those kids, hard to get a rapport going, but a lot of times I've seen students do beautifully with these kids. And, they are very literal. One of the very autistic children that we were taking care of, the student went in to give medicine, and the patient said to the student, "Your hair is a mess. In fact, you are a hot mess." This was a 6-year-old. And the poor student, she turned so red because her hair was very thin and it was kind of flyaway. And she goes, "Well, I tried to fix it, but my hair is real thin." And the little girl just said, "You're a hot mess." Just continued with that. It was like, wow. She came out so red and so embarrassed. I said, she just says what she thinks. You can't help it. Your hair is fine. It's up. It's the best. It's up as best as it can be. So let's not, and she's been a nurse now, I think, I don't know, 12 years. And she always sends me messages from the hot mess. But little kids can be very literal when they have those conditions. Cerebral palsy, we do see there's 3 or 4, like I said, frequent flyers at Cottage Pediatrics, and they are part of the community. They are, kids that we definitely see. The last one was in with rotavirus, and they are compromised, so they do get things easily. This one is fed with a tube feeding, and I think she's 13 years old now, but has the body of probably about a 4 or 5-year-old. And you can see she was anoxic at birth. It says affects the ability to move or maintain posture due to a brain damage before birth or early in life, caused by a variety of factors. So genetic, trauma, or that's prenatally anoxic. This child was born with this. Perinatally, fetal distress, drugs at delivery or breech delivery with delay, and then postnatally, the kernicterus or a high bilirubin or a head trauma. So there's a lot of different things that could cause a palsy, and types of cerebral palsy in areas of the brain. This is a really great picture that shows you kind of what the posture will look like and which area of the brain is infected. So regional involvement. And then you see here quadriplegia, diplegia, hemiplegia, and then the dyskinetic. Dyskinetic would be athetoid, and dystonic, ataxic or ataxia. The areas of the brain that are affected: normal, mild, and then severe involvement. The ones that we see in the hospital, those 2 are girls, and then 1 is a boy, and 1 I haven't seen in several years, but those patients they were anoxic at birth. They had like a birth emergency for those 3 patients for sure. And it doesn't mean to say that you're not going to see different ones from other areas that will come in. Safety, we feed them in an upright position. They are always with seizure precautions. The 2 girls that I know, they don't ambulate at all, but they are put into wheelchairs so they can kind of sit up for posturing. They ambulate with assistance if they're able. And then administration, nutritional needs include, they need increased calories, assist with feeds. And those 2 girls are G2 feeds. I don't know about the boy. They get speech, occupational, and physical therapy through children's services right at birth. The services are offered right at birth. So that's a big deal. These different charts give you an idea of the monoplegia, triplegia, hemiplegia, diplegia, quadriplegia for spastic cerebral palsy. And then what are the treatments? Maintaining these patients is generally what is done. I mean, it depends on what extent they are. They take medications to help with the rigidity. They do different adaptive measures so that they can maybe sit in a chair, or help with the handling of things, different walkers and types and such, depending again on the severity. And then if they can move, that's one thing. The 2 girls I know, I don't know again about the boy, but the 2 girls are definitely in bed. They have wheelchairs that are kind of almost lying up, so at least they can sit up a little bit and see what's going on. But it's a difficult life. It's a difficult life for the family. Oftentimes you'll see the parents get a respite when the kids are in the hospital. I mean, they get a respite, and they know they're in good hands, and they've really entrusted the pediatric community to their children because they know that they're very versed in it. They understand what's going on. We're almost done here. We're just going to finish with these slides, and we'll do the musculoskeletal the following week. But Duchenne's muscular dystrophy is most common. Gradual degeneration of the muscle fibers. So begins to show about 3 years of age, difficulties running and climbing stairs, follows to difficulty from sitting supine in a supine position. Profound muscular atrophy continues, and usually in a wheelchair by age 12. It's really spotted off usually with the climbing of the stairs, because some little kids can just get up a stair real quick, and when a little child is having a lot of difficulties, it'll be noticed. Respiratory and cardiac muscles are effective, and death is usually respiratory and cardiac in nature because those muscles become atrophied and they're unable to function. A diagnosis is made with a physical exam. They do a muscle biopsy and EMG, serum studies, the AST, aldolase, creatinine phosphokinase high at first 2 years of life, and that will definitely lead healthcare providers to understanding what the symptoms are and to what the condition is. Maintaining optimal level of functioning to help the child and family cope, because the progression and limitations of the disease increase with time. They don't get better. Okay, let's see what we've got. You see the Gower signs using their hands. They are able to move in such a way, but if you see the posturing on the left, this is a definite sign. They have weak muscles, like it says weak butt muscles or hip straighteners. They have swayed back. Their tummy sticks out usually. They have a really hard time sitting up. Thin, weak, tight are their thighs are very, they atrophy first almost. So standing up is hard. Their thick lower leg muscles are mostly fat. Tight heels, so they're on their tippy toes. They get foot drop very easily, and then like the shoulders kind of swayed back when they try to move. At this stage where you're looking at this patient on the left, you can see they sometimes have the hand sticks, the walker sticks that help them balance themselves if they're, already walking a little bit older. But you see over here on the other side where the child pushes his leg back to stand up, those are kind of just signs and symptoms with progression. Immobility is usually the musculoskeletal dysfunction, and maintaining optimal functioning, of course, would be the biggest objective, but generally just hoping that you can promote general good health, facilitate the compliance. So meaning that there's a whole healthcare team that's involved. It's not just the nurse and the family. They've got, again, speech, OT, PT. They have different groups where kids can go and they get like a general physical therapy in groups, to where it's almost like not an actual like Zumba class, but they have exercise classes where they can, maintain what they have or kind of try to build on what they have. Skin integrity is super important. And like safety considerations at home would mean, sharp edges, coffee tables, things like that, mats where they could trip over, that kind of thing, to keep the house kind of safe so that a child can maneuver around in their space. Pain management, because of the muscle strictures and whatnot, can be something that can be difficult on the family, helping support the child and the family to keep kind of like a level of pain at bay. So the different kind of medications, let me see what I'm having such a hard time with my mouse today. So the Duchenne's, they have, onset 3 to 5 years, primarily in males, and the Gower's sign, to where they are having a hard time moving. They'll move their thighs, they'll move their legs to stand up. They have like a waddling gait. Ambulation is impossible. Usually by age 12, 10 or 11, they start using a wheelchair, but not for everything. But then usually by the age of 12, they're bound to their wheelchair. Breathing muscles are mostly affected. So oftentimes these patients are on, mechanical ventilation to where they will, if they are trach, they get mechanically ventilated, and usually it's at night. It usually leads to death by the age of 15 to 18 years of age. History of motor developmental delay, clumsiness, frequent falls. They have a hard time climbing stairs. Riding trikes is kind of like the ages 2 and 3 where it's kind of first noticed. And then for nursing considerations, you look out for the fatigue and mobility. They have frequent infections, trying to maintain a function. But the one that isn't emphasized enough is the psychological effects. It is very debilitating, and it can be, something that is not just debilitating, but it's just so psychologically depressing for these kids. They kind of know what the outcome is. A patient in Santa Barbara that we had for home health, he lived to be 36 years old. His body was almost, I think, probably not even 2 feet long, but his head was of normal size. He was on a respirator, a trach, he suctioned, constantly. He had a nurse 24 hours a day. And he was doing fine and fell off his ventilator in the middle of the night, and the nurse did not hear the alarm, and he died. But you see there, it says 15 to 18 years. His brother died at 17, and he was 36 years old. He had the use of one thumb. He was a Laker fan. He watched all the Laker games. He could communicate perfectly. We had to cap his trach to talk to him, but he wanted to talk. And I was the night nurse. So it was brutal to try to stay awake. And he waited all day for me to come so he could talk. And the nurse, I was only there once a month, but the nurse that was there, she was there all the time, and she just adored him. So imagine how horrible she felt that she did not hear the vent alarm and she lost him. By the time the mother heard the sound and was running in, she was already doing CPR on him. So it was really just so unfortunate. And the mother was such a great gal, and she took such excellent care of him all day long that he lived that long. I don't know what she did, but it was really good. So again, this is kind of the progression. The symptoms arise around 3, presents as an inability to keep up with other children. 6 years, contractures in the gastric, soleus, ITB, TFL are present, and as well as toe walking and lordotic posture. So you see that lordosis in the spine. And it goes through, again, a generalization. This isn't every patient. Like I said, that guy lived 8 to 10 years. It goes to 12, 95%, 16, and then, there's morbidity. That isn't something to memorize. It's just kind of to understand it. This one was muscular dystrophy patient's quote, and it is kind of a jerker. I want to share with you what this means to me. I've been through a lot in my life. I have been close to death a couple of times. I remember doctor saying, I do not think you will live through the night. Each time I think about the near moment, how close I was to dying. It takes a lot of courage and strength to move forward. I now have a great outlook on life. It is something precious. Never take it for granted, because I could be gone in an instant. So I want you to cherish your life and not worry about material things or problems you may have. There is always a struggle. Just keep in mind that you only live once. There is not a second chance. Live every moment as if it was your last. And that was Jay. I often thought this was my guy, but it wasn't. He was a C. So this is nothing. This is a pediatric summary. You know about that, but we still have more stuff to go to. Required reading, and look at these. I do want to let you know that we will do, I'll show you real quick. going to just show you the planner before I let you run off. I can't wait to see you on Friday because I want to get through all of our IV sticks that we can. Hydration, don't forget. So here in week 8, this is where we are. I'm going to move that one down here for after our PEDS quiz, and we'll finish up. So we have just the musculoskeletal, and it shows you, and the neuromuscular. We did neuromuscular, yes. So just the musculoskeletal. I'll move down to week 9, and quiz 3 is next week. Let's see. I'm going to stop sharing so I can talk to you about what's going to be on that quiz. How's that? Let's see.
Linda, we have 4 quizzes plus the midterm in 8 days. And so I'm just wondering, we do not have mother newborn lecture on the Thursday, the 3rd. Do you think you could consider moving the PEDS quiz to that date? Just wanted to throw that out there.
Who's throwing that out there?